Good evening, everyone. Can you hear me okay? Great stuff. Okay. So this was the case I showed on Monday. And thank you very much to the very kind doctor who sent me an email and told me how to correct my videos so I don't have to keep on granting access every time. So that was really helpful. Thank you. Um, and what we've got here is we've got an anterior mediastinal mass by virtue of the fact that it fades above the clavicles. So there's the anterior component. And we've also got a middle mediastinal mass just here because the epicenter is just behind the anterior tracheal wall. The aortic knuckle can be seen because there's aerated lung adjacent to it. And this was a case of lymphoma, which you can see very nicely. Okay, what have we got here? Somebody wants me to explain the cervicothoracic sign. Okay, let's go back because this is quite important. If you have a mediastinal mass lesion that fades above the clavicle, so that's not at all well defined above the clavicle, it's an anterior mediastinal mass. And therefore, it's most likely to represent a lymphoma or a thyroid. Okay. Now, in this particular case, it's due to a lymphoma because of all the other features. Okay. Whereas the thyroid tends to be solitary. Now, if it was a middle mediastinal mass on its own, you might expect the aortic knuckle to be silhouetted out. Okay. Now, there is evidence of some middle mediastinal pathology, maybe just there, because it's in front of the trachea, and maybe just there because the epicenter is just in front of the trachea. But otherwise, it's predominantly a multi-faceted anterior mediastinal mass. So somebody says, if it goes above the clavicle, is that a positive cervicothoracic sign or negative? Do you know what? I can't remember. All you say is to the examiner, because of the cervicothoracic sign and the fact that the lesion is fading above the clavicle, this is anterior. Okay. Whether it's positive or negative means nothing really. I would be more descriptive. I hope that helps. Okay. This is a patient who has got an air bronchogram, progressive massive fibrosis, subpleural nodular change, bronchiovascular beading, subcarinal lymphadenopathy, paratracheal lymphadenopathy. This is sarcoid. Okay, it's a slam dunk sarcoid. And this is the same patient, the chest x-ray, and we can see the progressive massive fibrosis and an air bronchogram and all the features which go with sarcoidosis. So the subpleural nodular shadowing, bronchiovascular beading, and on the axial, you can see, not necessarily in this case, but if you look a bit lower down on this particular examination, you'll see bronchiovascular beading and subpleural nodular shadowing. Okay, so this is sarcoid. Okay, this patient is complaining of pain. Not small bowel obstruction. This is called meteoristic bowel. Air swallowing in the bowel. Yeah, so we've got a lytic lesion in the subtrochanteric region of the femur. And what about the acetabulum on the left? The cortex has gone. And it just so happens that this tube is overlying it. But the cortex has definitely gone. And there's another lytic lesion here. And I'm not sure about that one. Probably it's okay. So we've got at least 3 lytic lesions, and then you go through your pathological sieve, METs from bronchial carcinoma, breast, thyroid, kidney, and then always think about myeloma. Okay, what have we got here? We've got a patient who's got a painful left leg. So we've got a lesion here. Now, I wouldn't jump to any conclusions about that until you've got a full-length femoral view. And it is predominantly diaphyseal. Okay, so there's the metaphysis, there's the epiphysis, and this is a diaphyseal lesion. Okay, so the expansile nature, the permeative border, makes this more likely to be an aggressive lesion, such as a metastatic carcinoma or myeloma or lymphoma. Now, it's not really a blade of grass because Paget's, if that was Paget's, it would have to be contiguous with the entire femur down to the subchondral bone. So if it was Paget's, it would have to be like this. Okay, and you get this blade of grass appearance. Sorry, I've done that the wrong way around. Try that again. So your blade of grass would be something like this. Okay, but it would be contiguous with the epiphysis, and that's Paget's disease. Okay, but this is discrete, and this actually turned out to be lymphoma. Now, you can't make that diagnosis on the plain film alone. You'd need more imaging. And when we look at the imaging, we can see that this patient has got a malignant lesion in the vicinity of the diaphysis. And one thing to note, if the MRI appearances show that the lesion exceeds the diameter and the extent of an X-ray, that's more likely to be malignant. So if I just go back, the plain film appearance showed the abnormality was there to there. Okay, but this is greater on the MRI scan. So that's a feature that this may well be a malignant lesion. And we've got soft tissue involvement. And the biopsy of that bone actually turned out to be lymphoma. Okay, what have we got here? This is a young male patient who's getting recurrent infections. This is really difficult, by the way. So don't worry if you don't pick it up. The lungs are okay. The heart is okay. The bones are okay. But look at bowel gases pushed over here, over there, over there. Splenomegaly. And there is the abdominal film of that splenomegaly patient. Splenomegaly, 3 causes: portal hypertension, lymphoma, and CML. Okay, so they're the 3 causes in the UK: portal hypertension, lymphoma, CML. Massive splenomegaly, on the other hand, where the spleen is huge. Think about CML and myelofibrosis. Okay, and then in other countries, it could be Kala-Azar, malaria. Okay, what have we got here? Patient's quite well. Yeah. So we've got 1, 2, 1, 2, 3. Sorry, I've just had a problem with my second monitor. Hope you can see that now. So 1, 2, 3, called Garland's triad, and this is sarcoidosis. Okay, so 1, 2, 3. Okay, what is going on here? Got paratracheal lymphadenopathy, right hilar lymphadenopathy, left hilar lymphadenopathy, subcarinal lymphadenopathy, Garland's triad. Okay, this patient is complaining of a lump in the leg. Yeah, so we've got myositis ossificans just here. Okay, myositis ossificans. So basically, you bleed into the muscle because you've traumatized it, then it undergoes ossification. Trauma. Yeah, we've got posterior dislocation. So this is wider at the top than at the bottom here. So this is posterior dislocation of the humeral head. Okay, tell me what's wrong with this patient who's recently had an operation in an attempt to remove whatever was going on this bit of the chest here. Not pectus. They've got scoliosis corrected or an attempted correction with a Harrington rod, but always look at the patient as if you're looking at the patient clinically, and you'll see lots of neurofibrometer. So there's the neurofibrometer. Does the neurofibrometer explain the scoliosis? Yes, it does. Does it explain the skin lesions? Yes, it does. And therefore, what's this chest lesion? It's probably a lateral thoracic meningocele or schwannoma. And it couldn't be removed because it was too complex. And this was actually a lateral thoracic meningocele. Okay, this patient has got wheeze and dyspnea and cough, not pyrexial. So eosinophilic pneumonia tends to involve the mid and upper zones. Okay, eosinophilic pneumonia, but it can be patchy, and cryptogenic organizing pneumonia tends to be patchy here, there, and everywhere, bit over here, and COVID pneumonitis tends to be mid and lower zone predominant, mainly lower zone predominant. But the yellow indicates patchy ground glass change. And this patient has got cryptogenic organizing pneumonia. Okay. Cryptogenic organizing pneumonia. There's a halo here and lots of ground glass change. And the key is it's always peripheral. Now, can it look like eosinophilic pneumonia? Yes, is the answer. And so usually practically you don't worry too much about what it is because both conditions are steroid responsive. Okay, what have we got here? Yeah, we've got carcinoid. It's forming a desmoplastic reaction. You can just see the desmoplastic reaction in the mesentery. We've got ascites, and the ascites is going around the liver and into the lesser sac. But this is a mesenteric mass lesion, quite typical of carcinoid. Okay, what have we got here? Yeah, posterior indentation of the esophagus by an aberrant right subclavian artery. Okay, this is pseudo ground glass change. So it looks like ground glass change, but look here and here and here and here. And this is due to the breast shadows. So move the patient slightly. The lungs look normal. And so this is pseudo ground glass change due to breast shadows. So don't overdiagnose ground glass change in patients with soft tissue abnormalities or large breasts on the chest X-ray. Okay, what have we got here? Scimitar, yeah. So it gets larger as we go out. I've exaggerated that really, but that's a Turkish sword. This right hemithorax is a little bit smaller than the left, very subtle. And if you wanted to look further, you could do a CT and just keep your eyes on this area here on the axial. So there's something draining into the IVC. Let's go back. So that is draining into the IVC. It should be draining into the left atrium. And so this is an anomalous, there's the right pulmonary artery, there's the pulmonary vein, and it's draining into the IVC. But it's only doing that on one side, so it's called a partial anomalous pulmonary venous drainage, or scimitar syndrome. Okay, what's the diagnosis here? Yeah, we've got Paget's of the radius. Okay. You can see the Paget's of the radius with bowing, cortical thickening, and trabecular coarsening. So this is a typical, it's a common condition in a not so typical position. Okay, what is the cause of this patient's hypertransradiant lung? For that last case, you can definitely not give a differential diagnosis of fibrous dysplasia. It can only really be Paget's disease. Yeah, this is hypertransradiant lung. But if you look here, there's the spinous process. Spinous process, the medial end of the clavicle is here. Medial end of the clavicle is here. So the patient is rotated to the left, and that's making this hypertransradiant. The number of vessels per unit area is the same. So this hypertransradiancy is caused by rotation. Okay, what's the diagnosis here? Yeah, retropharyngeal abscess, and you can actually see the necrotic tissue in the abscess itself. That patient was immediately intubated after that X-ray was taken. Okay, 82-year-old female with swelling of the thigh. Yeah, osteosarcoma. So we've got dense bone, got Codman's triangle, and we've got this soft tissue mass here and here with calcification. And then the entire thing is just, sorry, I'll draw that again. Not very good at drawing. So there's the soft tissue component just here. And then we've got Codman's triangle just there. And then we've got this malignant looking calcification. Now, if you ignore all of this and just look at the femoral condyles, you would probably come to the conclusion that this is Paget's disease of the femur compared with the tibia. So this is a Paget sarcoma. And of course, elderly patients don't get sarcomas unless they've had Paget's first. So this all fits. Okay, 9-year-old child falls on the outstretched hand. What does that say there? No, it's a right-sided humerus. The other view didn't show fracture. What's this here? Yeah, there's a mass lesion projected over the right midzone. Do a chest X-ray. Can I see the right heart border? No. Can I see some blood vessels converging on the hilum? Yes. Is it fading as it goes towards the mediastinum? Yes. Is it sharp peripherally? Yes. So it's a mediastinal mass, and because I can't see the right heart border, and I can see blood vessels going towards the hilum, it must be an anterior mediastinal mass. And so the most likely cause in a child is going to be a teratoma, but you still need to work it up. You can do an MR or a CT, either is totally acceptable. And well, here we've got a CT scan which shows calcification, fat, and soft tissue density. And that was a benign cystic dermoid or teratoma. And there was no fracture. Yeah, there was no fracture. So the MSK angle was a red herring. Premature neonate. Yeah, it's RDS. Can't see the right heart border, can't see the left heart border, can't see either diaphragm because the lungs, instead of being aerated, are just full of exudate, making the heart and the diaphragm obscured. And we've got air bronchograms very nicely shown. So we've got a nice demonstration of air bronchograms. Now we've got two other problems. The first problem is that the NG tube needs to be a bit lower, so it needs to be advanced. And the ET tube is a bit low and needs to be pulled back a bit because it's now intubating the right main bronchus. And you can see the sternal, the intercostal recession and very marked consolidation, which of course would fit with RDS. Okay, have a look at this one and tell me what you think. Yeah, so we've got lung lesions, we've got polycystic kidneys, got renal transplant. So this is likely to be post-transplant lymphoproliferative disorder. Diagnosis here. Yeah, LCH, we've got nodules and cysts, different shapes, different sizes, and sparing of the CP angles. Diagnosis. Yeah, we've got a giant cell tumor, so it's in the epiphysis, it's a fused skeleton, it's well defined medially, and laterally, it's broken the cortex and it's expansile. So this is a GCT. Okay, same again, it's just affecting a finger. So it's exactly the same. Fused epiphysis, adult patient, epiphyseal lesion, smooth, well-defined on one aspect, and then cortical breach on the other. Can it be a glomus tumor? Not really. They tend to be fingertip and they tend to be fairly central. So I don't think so. Okay, what's the diagnosis here? Um, the previous case was a giant cell tumor. Now, if you look at the distal interphalangeal joint, you can see juxta-articular erosions. Juxta-articular erosions. There's one there, several there, several here, several there, and this is gout. Okay, this might be difficult to see, but what's the abnormality? While you're wondering, the previous diagnosis was gout. Yeah, so we've got a retrocardiac opacity just here. Okay. Ignore that. I don't know why that's come up. That was on the previous one, wasn't it? So try again. Got retrocardiac opacity just there. And that's in the left lower lobe. Right, somebody's asking me about gout. This I'll go back because it is quite important, so I will mention it. It's gout because we've got juxta-articular erosions. Okay. Juxta-articular erosions, juxta-articular erosions. There you go. So it's absolutely characteristic of gout. Okay, this patient is complaining of weight loss. Yeah, there's a lung mass just here. Okay, seen on that abdominal film. Diagnosis here. Yeah, there's an expansile lytic lesion of the clavicle, most likely to represent myeloma, although it could be metastatic carcinoma from, say, something like a thyroid or a renal malignancy. That was myeloma. Okay, what sort of arthropathy is this? Yeah, we've got hook-like osteophytes, second and third MCP joints with joint space narrowing, hook-like osteophytes on the other side too. And this is a patient who has got CPPD, in this case caused by hemochromatosis, because we've actually got triangular cartilage calcification. Okay. There it is, triangular calcification there. Okay, what's going on here? Knee pain. Yeah, there's a small effusion. And then so there's the effusion. That bone is dense. Compared to that bone. And there's a periosseal reaction just there. And this is an osteosarcoma. And when you do the MRI scan, you can see it's very extensive. There's a lot of soft tissue swelling there. So in retrospect, this is not an effusion. It's actually due to the soft tissue swelling associated with the tumor. So that's the tumor. But you would never notice that until you did the MRI scan. So this was a sarcoma, osteosarcoma. Okay, and the same patient then developed a spontaneous pneumothorax. And they've got a loculated hydropneumothorax. And there is another metastatic osteosarcoma lesion in the right lung, right upper lobe. What's the likely diagnosis here? Could be a Sagar tumor. Could it be anything else? Yeah, it's a lymphoma. Lymphomas tend to cross the midline. They tend to be around the ventricles, and we've got another focus here. So if it was a Sagar tumor, it would just be confined to the foramina of Monro. To my knowledge, and correct me if I'm wrong, but the Sagar tumor would be most unlikely to be in two places. Sorry, I've just had a bit of a sneeze. Okay. Okay, so we've got, excuse me, this is cerebral lymphoma. Okay, this is a swelling of the knee. Yeah, osteomyelitis. So we've got dense bone, a lucency here. We've got soft tissue swelling over that lucency and soft tissue swelling here as well. And when you look at the frontal view, you can just see that there is loss of trabeculation and a kind of ground glass impression, almost as if that's been hollowed out. And so when we do the MRI scan, it looks not dissimilar from that lymphoma, except we've got a sinus, which you get with osteomyelitis, and this is fairly damning evidence that it's osteomyelitis. You don't tend to get the fistula or the sinus with lymphoma. Okay, excuse me. A jogger with painful ankles. Yeah, stress fracture. Stress fractures are typically perpendicular to the long axis. You can just see some periosseal reaction just there. There it is, just there. And this patient has got a stress fracture. Now, what happens here is that the patient has a dense line because the trabeculae from the top are overlapping with the trabeculae on the bottom. And so, and where they overlap, that gives you a density. Okay. And so this density is of a stress fracture. Diagnosis. Yeah, tuberosclerosis. So we've got calcified tuber here, calcified tuber here, and we've got signal void because it's calcified in the ventricular system. So this is subependymal hamartomas or tubers. And so it's fairly typical of tuberosclerosis. How would you describe that elbow? Yeah, all the Ds. So it's distended, it's dense, it's disorganized, there's debris. And so this is a Charcot's joint. And when you note that it's a Charcot's joint, you should always then consider syringomyelia. This patient has actually got similar changes in the shoulder. And there's a Charcot's joint of the shoulder. Now, that's easy because you can see it on the shoulder film. There's another view of the elbow, but you may subtly miss it. There's a normal left shoulder and there's the abnormal right shoulder on the chest x-ray. So you want to get a better view. There it is on the chest x-ray. There is the Charcot's shoulder joint. Okay, so this patient presented with chest pain. Pneumomediastinum, yeah. So we've got the V sign of Nacclerio, which is here, just there. And you can actually see lucency, streaky lucency going up into the neck. What's this condition? This is synovial osteochondromatosis. Okay. Yeah, the V sign of Nacclerio, it's trapped gas between the parietal pleura and the mediastinum. Okay. And it tends to be in that position there, that lucency there. And it's a sign of pneumomediastinum. So obviously, pneumomediastinum, the one that we most fear is the patient who's got an esophageal rupture, but that's usually diagnosable by the history. But if you need to do a contrast swallow. Okay, somebody saying why not tumoral calcinosis? Because it doesn't look like tumoral calcinosis. That tends to be around the joint, but it's much bigger than that. Whereas these are small, discrete lumps, different sizes. This patient's had a post-traumatic arthritis of the glenohumeral joint. You can see an old fracture there. And therefore, this is secondary osteochondromatosis because there's been a previous OA problem. Okay, abdo pain. We've got streaky gas. We've got gas which is very lucent and trapped up there. And we don't show it on the abdo film, but because the abdo film is going to be supine, but we can see just a sliver of peritoneal gas. Sometimes you might see it on the supine film, but not always. And then the patient has got gas around the kidney, and this is expressed in the coronal CT. Gas around the kidneys and aorta. There's pneumoperitoneum. This is probably due to a perforated sigmoid diverticulum. So the fact that you've got retroperitoneal and peritoneal gas means that the perforation has occurred maybe at the rectosigmoid junction. Okay, what's this? Why not a duodenal ulcer? Well, it could be, but in this particular case, it was due to a perforated sigmoid diverticulum. But you're right, you can't tell on the plain film usually, but on the CT, if most of the gas is located around the sigmoid and you've got diverticular change, that's how you make the diagnosis. Yeah, so we've got normal visibility of the aortic knuckle, but we've got filling in of, so the pulmonary trunk is seen there, and then it merges with this mass lesion, which fills in the pulmonary trunk and the left atrial appendage. Then we've got paratracheal lymphadenopathy just here. So this is most likely to be lymphoma. And again, we've got a movie. And you can see that most of that mediastinal mass lesion is located in the anterior compartment up here. And we can see the aortic knuckle because it's anterior. Okay. But when this mass lesion touches the pulmonary trunk just there, you lose the ability to see the pulmonary trunk. I think I showed you this a couple of days ago. This is bilateral carotid body tumors, or is it? No, sorry, I beg your pardon. It's unilateral, different case. It's splitting the carotid arteries because it's occurring at the bifurcation. You sometimes might see the salt and pepper effect, but not always. And this is a very nice example of a carotid body tumor at the bifurcation. Diagnosis? A mieloblastoma, yeah. Mieloblastoma. A mieloblastoma of the jaw, just here. Okay, this patient has got non-specific pelvic pain. This is looking at your review areas. Yeah, we've got metastasis involving the proximal femur. So it's a lytic metastasis. It seems to be involving the so endosteal scalloping, and this turned out to be myeloma. Get a full view of the femur, and they go, the endosteal scalloping favors that this is myeloma. Okay. It can occur with the other things I've mentioned, but this was a patient with myeloma. Okay, back pain. Yeah, we've got sacroiliitis. I wouldn't say they're fused, but they're definitely inflamed or eroded. And this is a patient with ankylosing spondylitis. What's the diagnosis here? Sturge-Weber, yeah. So we've got this gyral calcification, so-called tram track calcification. And why is the skull vault thickened? Sorry, that's my dog barking. Yeah, anti-epileptics, well done. So anti-epileptics tend to cause thickening of the skull vault. And this is the same patient. We've got calcification of the gyri, and then thickening of the skull vault. Okay, this is a child, and I want you to tell me why the child is unwell. Could be sequestration, although that usually occurs on the left. Could it be consolidation or a rounded pneumonia? I suppose it could. But let's have a look at the CT. What does that show? Yeah, it's a posterior mediastinal mass. Okay, and it's calcified, and there's a small pleural effusion. Beautiful demonstration of the obtuse angle that a mediastinal mass makes with the mediastinum. Okay, Paddy, that's my dog again. That's not me. So I will show the X-ray again because it's quite an interesting case. And there is the patient's chest X-ray. And you can see the right heart border is intact, but this is a very ill-defined lesion, certainly here, and ill-defined here, and it's a bit sharper here. And that's a posterior mediastinal mass lesion. That turned out to be neuroblastoma. A neuroblastoma. What's my dog's name? His name is Paddy. Okay, what's the diagnosis here? Yeah, it's hydatid. So pretty typical of hydatid disease in that we've got rim calcification, we've got the water lily sign, okay, and that's just the daughter cysts floating. It gives the impression of a lily floating on water, but these are the daughter cysts. And this patient's got hydatid disease. Some of them are calcified, but that doesn't mean that they are inactive. What is the chance of rupture in liver hydatid? Your guess is as good as mine. I don't know. But clearly, that could be an issue, couldn't it? So it's important that you don't needle the abscess or the presumed abscess. And once you see that, you need to get the interest of a liver surgeon who can take those out in an operation. Okay, that's me done. I'll see you on Monday. Hope you found that useful.
Here comes